Pancreatic fistula. An overview. A pancreatic fistula is an abnormal communication or leakage of pancreatic fluid from the pancreatic ductal system to surrounding tissues or cavities. It is a common and potentially serious complication following pancreatic surgery, trauma, or pancreatitis. Types of pancreatic fistulas. 1. Internal pancreatic fistula, leakage into surrounding internal structures such as the peritoneal cavity or pleural cavity, can lead to conditions like ascites or pleural effusion. External pancreatic fistula, leakage of pancreatic fluid through an opening in the skin, often post-surgery or trauma. Causes and risk factors. Surgical procedures. Pancreaticoduodenectomy, Whipple procedure, distal pancreatectomy or other pancreatic surgeries. Trauma, blunt or penetrating abdominal trauma, pancreatitis, severe acute or chronic pancreatitis, neoplasms, tumors affecting pancreatic ducts, endoscopic interventions, ERCP, endoscopic retrograde cholangiopancreatography with complications. A pathophysiology. A pancreatic fistula occurs when there is disruption of the pancreatic duct, leading to leakage of enzyme-rich pancreatic secretions. These enzymes can digest surrounding tissues, causing inflammation, infection, and tissue necrosis. The presence of active enzymes increases the risk of complications like abscesses, pseudocysts, or peritonitis. Clinical presentation: persistent abdominal pain, fever due to infection or abscess formation, elevated drainage from surgical wounds if external, features of pancreatic ascites or pleural effusion, dyspnea, distension, etc. Signs of sepsis in severe cases. Diagnosis: 1. Clinical assessment, monitoring for abnormal fluid leakage post-surgery or trauma. 2. Biochemical analysis, elevated amylase content in drained fluid greater than 3 times the serum amylase level suggests pancreatic origin. 3. Imaging, CT scan, to identify fluid collections, abscesses, or pseudocysts. MRCP, magnetic resonance cholangiopancreatography, for detailed visualization of the pancreatic duct. ERCP may help identify the site of ductal disruption. 4. Serum markers, elevated inflammatory markers, CRP, white blood cells, reduced serum albumin in chronic leakage. Management, conservative treatment, nutritional support, total parenteral nutrition, TPN, or enteral feeding via jejunostomy to reduce pancreatic stimulation. Somatostatin analogs, medications like octreotide to suppress pancreatic secretions. Drainage, percutaneous drainage of fluid collections. Antibiotics, broad-spectrum antibiotics for infection control. Interventional or surgical management. Endoscopic interventions, ERCP with stent placement to promote ductal healing. Surgical repair, indicated for persistent fistulas or complications like abscesses or pseudocysts. Distal pancreatectomy for fistulas associated with distal pancreatic pathology. Laparotomy to manage peritonitis or complex cases. Complications: infections, abscess, cellulitis, or peritonitis. Malnutrition due to loss of digestive enzymes. Electrolyte imbalances resulting from prolonged fluid loss. Chronic fistula formation, persistent fistula that does not heal despite intervention. Pancreatic pseudocysts, encapsulation of leaked pancreatic fluid. Prognosis. The prognosis depends on the cause, severity, and timeliness of treatment. With appropriate management, most pancreatic fistulas can be resolved. However, severe cases with complications like sepsis or multi-organ failure have a higher mortality risk. Prevention. Proper surgical techniques and postoperative care. Early recognition and management of risk factors like pancreatitis or trauma. Use of somatostatin analogs during high-risk surgeries. This detailed approach to understanding pancreatic fistulas highlights their complexity and the importance of multidisciplinary care in managing this condition effectively.